good morning, everybody, and welcome to the latest in this series of Health Tech World Roundtables. And this morning, we're focusing on ageing, and particularly ageing well. We've got a fabulous group of panelists who will ask to introduce themselves in just a second. But just a reminder that during the course of the conversation we have this morning, if you're watching, there's an opportunity to ask questions or maybe raise any issues that you might have. And if you'd like to do so, please just put them in chat and I'll try to make sure that we cover any questions or any thoughts or any issues that you'd like to raise if you're watching this morning. Similarly, as soon as we finish, we'll be loading the content and the discussion from today up onto YouTube. It'll also be in the Health Tech World website. So please, as we cover the discussion today, and particularly after we close, share that as widely as you can so that as many people as possible can participate in that discussion after we finish, because I'm sure the discussion will move forward, both in social media and possibly directly with some of our panelists as well. So without further ado, we'll move into our discussion, and I'm going to start by asking each of the panelists just to say a little bit about themselves, the organisations that they're either affiliated to or that they work with in some way, and to talk just a little bit about their particular areas of interest, and then we'll move into the body of the discussion. So if we can maybe start with you, Alex.
Sure. Hi, everybody. Thanks very much for inviting me to join this discussion this morning. I'm really looking forward to it. My name is Alex Craig. I'm a partner at Muckle LLP, which is a commercial law firm based in Newcastle. My particular practice area is to head up the commercial team, which is the team that does the sort of nitty-gritty day-to-day business advice around contracts, IP, technology, and data protection. And from the point of view of this morning's discussion, my particular interest is on the data protection side of things. This whole opportunity that we have to use through the technology that's now available to us, the data that we have in relation to individuals, organizations, the way we operate, work, move, all of those things, gives us huge opportunity to try and look at how we might support individuals in aging and look at well-being from that point of view. And indeed, we're seeing quite a lot of activity from those involved in the medical profession or on the periphery of the medical profession, and looking at challenges that they see day to day and perhaps applications of technology, which then results in real kind of investigation around the data side of things. So that's my interest.
Great, thanks very much, Alex. And I'm sure we'll come back to the question of data quite possibly in connection with AI and how that might play a role in diagnostics as we move forward. Shadi, if I could come to you next, please.
Sure. Hi, everyone. My name is Shadi. I'm Chief Medical Officer at Unisi Health, a startup based here in Israel. I'm an MD by training, studied medicine, practiced medicine for over 10 years, including doing residency in internal medicine. Before Unisi Health, I founded a vocal biomarker startup where we developed technology that can analyze voice and detect the patient condition based on voice analysis. I joined Unisi Health about 6 months ago. And at Unisi, we developed a device that uses infrared and can monitor patients at home, contact-free, to detect multiple parameters like pulmonary congestion, the level of fluids in the lungs of the patients, heart rhythm problems, heart rate, respiratory rate, and we're currently developing other capabilities to add to the device.
Thanks very much, Shadi. That's great. Norman, would you like to introduce yourself, please?
Yeah, hi, my name's Norman Niven. I'm absolutely delighted to be here today. The fact that I was pushed into it by Paul is nothing to do with it. It was extremely interesting and I was delighted. My background is pharmacy and my career has been spent developing products which improve adherence and reduces non-adherence. So I developed one of the first monitor dose systems in the UK, Nomad, then developed another improved monitor dose system that allowed liquids as well as tablets to be packed into a monitoring system. I was also a director of Bupa, and then I came back out again to set up a company to develop assisted care products, which was Tell Me Now. And then recently, most recently, I set up a company called Medication Support Limited, where we've developed a remote monitoring service called Payman. And we monitor people at home taking the medication to make sure they take the medicines correctly. We use pharmacists and pharmacy technicians to do this. And it's the first anywhere in Europe and possibly in the world that does that. We work with councils, Liverpool in particular, we started with, saved them over £500,000 per 100 patients in the last year. We work with Knowsley, we work also with GP practices, dispensing practices, and we're also about to work with pharma. So my special area of interest is how people take the medication and making sure that they take the medications correctly. So I'm very, very interested in adherence and non-adherence, because both of those have massive inputs or massive influences on health outcomes, and it's the health outcomes that ensure a happy and agreeable long-term aging process. And we're also very keen to improve the quality of life of the individual patients as well, and that also comes out of the fact that if you can take your medication properly, health outcomes mean that you're going to be happier, independent, and you feel safer. So that's my focus, is adherence and non-adherence.
Thanks very much, Norman. Whether you volunteered or coerced, we're really pleased that you're with us. If I could ask you to introduce yourself, Naji, please.
Yes, well, first of all, thank you very much for inviting me to join you this morning. So I'm Professor Naji Tabit. I'm Professor of Dementia and Old Age Psychiatry at Brighton and Sussex Medical School. And I'm a consultant old age psychiatrist, dementia specialist at Sussex Partnership. And I mentioned Sussex twice, medical school and the trust. And this is aging and healthy aging. And Sussex is a place where the prevalence of conditions associated with aging is exceptionally high. We have a very old population, the oldest in the country, especially on the Sussex coast, and a very, very old population, people above the age of 80 or 90, things like Bexhill-on-Sea and Eastbourne and so on, towns are associated with aging. So yes, we're very much interested in supporting people age well and keep them away from us, but when they come to us to live well with their cognitive impairment and other mental and physical health problems. I'm also the lead for the NIHR Applied Research Collaboration for Kent, Sussex and Surrey dementia team. And one of our important sub-teams is digital health and assistive technology. So we're always looking for, opportunities to work with people, both in the NHS, industry, and other sectors, to try to, test and help advance really assistive technology and digital health. One such a successful venture was partnering a couple of years ago with a startup company and getting just under $1 million from Innovate UK to test a digital iPad-based diagnostic test. And about a few months ago, we made it to BBC Click. So we must have done something right. And this is an example of NHS working with the industry supported by the government to move forward when it comes to health. So we're very much interested in assistive technology from all aspects, and we're funny enough, surprisingly, we managed to get some money from NIHR Applied Research Collaboration to start working on a, colleagues call it monitoring app, but actually it's a supportive app to support people and their carers who've been diagnosed with memory problem or their cognitive impairment or more serious dementia.
Thanks very much, Naji. And we'll definitely come back to that question of economics. That was a great partnership model and exactly how we fund some of the developments that we touch on. Last but not least, Stian.
Good morning from Norway. I'm Stian Lavik. I'm the Chief Business Officer of a company called Motitech, a Norwegian company set up on the West Coast here in 2013. From 2017 on, me and some colleagues have been building up Motitech in the UK, and what we deliver is video and cycling in care facilities. So this is actually to support and facilitate for the intrinsic motivation to be more physically active in a setting where you're usually deprived of that kind of opportunity. And we have seen very strong and complex benefits from this. Obviously, what you would expect from physical activity, physical benefits all over the place, and also strong benefits in terms of well-being, general contentment of life, quality of life in that sense, and not least on the social side of things. Because what we do is that we deliver a global video library. So it would, you would sit inside doing cycling with a specially adapted indoor exercise bike, and you would have the sensation of being outside cycling on the roads. So typically people would travel to places they know or places they wanted to visit virtually. And then the fun starts, because then you start sharing your stories about these places and you talk to each other. So the social aspect is really strong. And together, these three pillars of physical, mental, and social really strengthens the motivation to get more activity into your life. So this is one vehicle of a larger vision of sort of enriching lives in terms of activity and well-being in this specific space.
Great, thanks very much for that, Stian. Perhaps as we're with you, Stian, I could maybe ask a question to kick the discussion off. We're talking very much about extending quality of life, and I suppose, you know, moving from healthcare to self-care for people who are aging. What do you think the big barriers and the potential big breakthroughs are with reference to technology enabling better quality of life for longer?
Sorry, I got caught out. Did you ask me the question?
Yes. Did you catch the question, Stian?
Yes, I think I did. So I think from our experience, we're now in about 850 care homes across 11 countries and more than 100 of them in the UK. I think what we see is that there is a need to make sure that everyone has a mindset of focusing on abilities instead of disabilities. I think that's where it starts. Because when you start doing that, you start trying to facilitate for and empower the intrinsic motivation and what people really want to do with their own lives. So obviously, we have a lot of technology that is crucially important to support living better in so many ways. But I think there is still a large need to focus on how could people sort of be empowered to live their own lives fuller, if that makes sense. So we love to cheer on every initiative that is going in that direction. I think that's a stepping stone number one. And then obviously there are a lot of other factors involved, like the all ongoing issue around funding and all of those things and structure and such. But I think it needs to start with a mindset.
Thanks for that, Steve. Norman, can I come back to your area of focus? How does the delivery of medicines and pharmaceuticals play into that sort of concept of people living well for longer and maybe changing their mindset from disability to ability?
Yeah, that's a very complex question, because the delivery normally within pharmacy, you presume is delivering to someone's house. So that's one element. The most important thing about medicines is that people take them. And one of the things that we are working very hard at is working with GP practices to look at closing what I call the medication loop. At the moment, people go into GP, they have a consultation. The GP writes a prescription, they come out, they go to the pharmacy dispenses the medicine, and then what? Nobody knows. So people get the medication, and the national average figure is around 55% of people are adherent. So that means 45% don't take the medication or don't take the medication as they should. Now, this is a really, really important aspect of how people can age well, because if you take your medication as you should, health outcomes are better. If health outcomes are better, people have a happier life. Also, the number of people who keep going to GP surgeries far more often than the average, those people go because they're not taking the medication, the health outcomes are poor, therefore they have to keep going to the GP surgery to get more medicines, and that reduces the time that GPs have. The other big issue is that the cost of non-adherence is absolutely staggering. So if you look at the UK alone, the cost of non-adherence to the UK economy is £3 to £4 billion a year. When you start looking at America and the States, who've done a lot of work on this, the average, I think it's in last year, the United States health costs were something in the region of $1.4 trillion. And out of that $1.3 or $4 trillion, $600 billion was wasted, medication wastage, because of non-adherence. And you imagine, even if we were to use the figure of 3 billion in the UK, that would go an awful long way to paying for a lot of the social care. And so what we're looking at is a way of integrating the care and the health aspects of managing medicines, which is what we're doing with our remote monitoring. So by doing remote monitoring and monitoring people taking the medication, we are able to improve the medication adherence from around 55% national, we're up to 97%. So basically, everybody we monitor is fully compliant, is fully adherent. And what we find is an amazing increase in quality of life from the individuals. So they feel happier, they feel more independent, they're a lot healthier, and so they can fully enjoy their life. And so what we have is a situation where we pay a great deal of money for drugs, many of which are not taken properly. And that has been one of the biggest problems. It's also, interestingly enough, the elephant in the room for pharma companies, because pharma companies themselves have a major interest in making sure people take the medicines, because at the end of the day, if they don't, then the outcomes are poor and they'll have to switch. So managing medicines, in my opinion, is the one key ingredient for having a healthy and prosperous and good aging process. So as you get older, control the meds and you control how well you can live.
Thank you, Norman. I'm sure we'll come back to some of those points that you raised, particularly around the economics, as well as the health benefits of what you described. Naji, we touched on issues there around the attitude to ageing and how important that is. I'm sure you'd like to make a contribution.
Yes, I would like to make and also comment what colleagues have already, both Norman and Stan already said, as far, as the concordance rate or adherence rate is like 50 or 60%. There was a study that showed adherence rate in ITU at only 90%. And you ask, how can people, reject their medication ITU? Probably, the study measured, doctors, nurses forgetting to give the medication. So that's an important issue, medication, especially among older people where polypharmacy become such a significant factor. And the team is developing about living well with aging, but also living well with adversity. Actually, our team at the Center for Dementia Study, which I'm the director at, and for the Applied Research Collaboration at IHR in Sussex and Kent and Surrey, is living well with dementia. And it's almost an oxymoron. How can you live well with dementia? But we have to remember that the vast majority of conditions in old age are very chronic conditions, and people live with them for many years. The median life expectancy for people with somebody Alzheimer's disease, for example, is 9 years. But that person would have had cognitive impairment maybe 3 and 4 years before then. But that doesn't, not just for, dementia, looking at diabetes, looking, hypertension, a host of physical ailment. Even cancer, where, even the deadliest of cancer, people are living longer and longer. Therefore, living well with the aging process and living well with adversity is very important theme, and things that we should really work towards. There's no perfect solution for everything, but working together really and supporting patients to get the most of what they have. And I always tell people training with me, and also patients and carer and so on, for somebody in their 25 years, it's a short time span. But if you're 80, 5 years is a lifetime sort of thing. You want to get the most out of your time.
Thank you for that, Naji. Alex, do you want to come back maybe and talk about the role of technology? And you touched on data with reference to improving that approach to self-care and quality of life and aging well.
Sure. As I said before, we've seen quite a lot of activity that's coming out of the medical profession. As I say, people who are really heavily involved within the NHS Trust, for example, or people who are sort of on the periphery. But either which way, the thing that's interesting is that they are recognizing that there are repeat issues, which is some of the things that we've talked about already. There are repeat issues which actually could be addressed by the use of technology in sometimes quite simple ways. There's quite a lot of sort of new applications that are addressing very specific problems that we're seeing. But the thing that is key from on the legal side in all of this is that we move away from considering the data protection legislation, which is now a lot more onerous and has a lot more risk associated with it, which is why it's so much higher on board agendas. But we move away from thinking of it as a block, and instead embrace what the regulator's trying to get us to do, which is to look at some of these new technologies and building the privacy elements in through the design process, rather than what we've tended to do historically. It's shifting now, but historically it would always be a kind of everything would be done, built, and then we think about the privacy angle at the end, whereas the idea would be that you're thinking about it all the way through, so that we build confidence, trust, and therefore get much better adoption of some of these. And it's frankly amazing, we were just hearing about the monitoring side of things. It's amazing some of the stuff that can be done and achieved through the use of technology in some of these quite challenging situations. But there's a privacy data angle usually to most of these, and it's about as I say, trying to look at it all instead of it being a massive block, trying to think, well, actually we need to embed it and build it in so that there's this trust associated with whatever technology it is that's being used.
Great, thanks for that, Alex. And Shadi, coming to you, I mean, you're like others on this call at the sharp end of innovating solutions that improve quality of life. Barriers and the big opportunities as you see them?
Sure. So I'll give you an example from my experience back when I practiced medicine. So let's take heart failure, for example. So we admitted many heart failure patients, they would come, they would have fluids accumulated all of their bodies, including the lungs, and they will have serious shortness of breath until, the point they even feel, they don't have air to breathe. And we would treat them for days, even more in the hospital, until we stabilized them. And then, they began to feel better and they went home. And once they go home, you actually don't have a lot of control what happens there. That's why many of them back in the hospital. So if we look at the medical literature, we know that about 20-25% of those heart failure patients discharged from hospital after heart failure flare-up, they will, about 20-25% of them will be back in about a month, 50% in a year. And that's why many companies, many startups began doing some, some cool things like help with technology to help these patients detecting their deterioration early, trying to provide them education, helping them with the transition from hospital to home, monitor them, detect them their deterioration early. And we do see that a lot of these things are helping and preventing readmissions. The problem with, with older people, many of them, they have memory issues. So they need apps to remind them to take their medications. Also for education. So once they're in hospital and you speak with them every day, they remember their condition, what they need to do and what they must not do. But once they go home and go back to their, previous environment where they have for example, salty food in their environment, they will eat that, and that's not good for their condition. They will forget about measuring their blood pressure. So you need devices and apps and technology that can first remind them to do that. Maybe do that passively to improve compliance and, detect this deterioration early, not just to tell the patient, but maybe tell the caregiver, the family member, or the healthcare team. Another thing to remember in this population is, a lot of them have mobility issues. So even when they begin to feel worse, they will try to stick at home, maybe take another pill of their usual pills. They'll not, go right away to the doctor. That's why many of them, continue to deteriorate until the point when they reach the PCP has nothing to do besides sending them back to hospital. So when you think about how we can use technology to address all of these needs, you need to take into account that, we're not talking about most cases, 20 years old patients. These are older patients, memory issues. They're maybe alone at home. Maybe once, twice a week only, someone is coming to visit them. They have mobility issues. So we need to take all of these things into account. And so for example, in our company, this is when we thought what we should develop to help these patients. And, we built a device that can measure the patient's contact free. It uses infrared. It looks at their chest while they're sitting for about a minute. So this device capture actually using infrared 300 frames per second, 300 photos per second. That's why it captures, the vibrations. Why is that important? If you think about it, when you go to a physician, you would put a stethoscope over your chest, right? And then the stethoscope has a membrane that detects the vibrations, turn that into an audio signal that the physician can hear. It says, okay, that's wheezing, that's asthma, that's crackles, maybe it's lung infection or fluids in the lungs, etc., etc. So it would have been great, for example, for all of these patients to have, a doctor or a nurse visiting them every day. But unfortunately, that's not the case, especially today when people are getting older with more and more conditions, and the number of people needing treatment is, far outnumber the number of people that can treat them. That's why it's important to use technology in order to do all of those, whatever a physician can do. If we can do that with a technology, with a device at home every day accurately, in order to, check these patients, detect deterioration very early in the course of the deterioration. This way, the medical team can be alerted. They can provide treatment earlier to this patient, not just, wait for him at the clinic until he shows up, until he seeks medical attention. And, looking at the medical literature, we know that providing treatment early in the course of the deterioration can improve health outcomes, can prevent readmissions, improve survival, and improve the quality of life, because, no one likes to feel sick. No one likes to be in the hospital. So what I'm trying to say, when you are addressing all of these problems, and, you need to take this specific population, their needs, their characteristics in mind in order, to develop something that will be unique, something that will be very user-friendly, that they can use, hopefully passively to, they don't need to do measurement every day. That should improve compliance. So for example, what we're doing now, so we have a device that is, in the size of a smartphone. So we're thinking, okay, it's already contact-free, non-invasive, non-intrusive. It does a lot of, it does great. But how we can also improve the condition of the patient. So still, they need to measure them every day, once a day. So what we're doing now, we're collaborating with a tech giant in order to take that device, minimize it to a small camera, put it in the TV in the living room. So every time the patient, will sit to watch TV, that device can automatically detect him and check what's happening with the patient, detect multiple parameters to detect deterioration. That's why, and this is how we think we can improve the quality of life of these patients.
Great, thanks, Shadi. Stian, can I bring you in?
Yes, there were just sorry for my sore throat today. Just a couple of points that I wanted to add. I think there's been a lot of good points being raised here around the table now, and I think we've seen a lot of key aspects that need to be focused on to be improved. I also think that if we look at the sort of the larger picture here, many of age-related disorders are actually caused by inactivity more than the age itself. And I feel we're missing out on a huge opportunity if we don't try to sort of put our efforts and resources where we can help people live their lives from their own perspective, and also as long as possible before coming into what we traditionally call the medical system or the health system. So obviously that is going to happen, and then all these points are really, really key and relevant. But I think we need a strong focus as a society to look on what can we do to prevent these things from happening. Some things obviously you do not prevent, but we have seen in relation to our technology that when people are getting physically active, especially with regards to pro-Renata medications, you can actually reduce it quite a bit because you're getting benefits from physical activity that would do these things instead. Now that isn't the whole picture, but I think it is a strong focus and a key point for the sector. And that also leaves us with my other point, then, that as well as the importance of coordinating health and social care better, which is underway and which is a huge debate that is going on at the moment, we also need to get a mindset shift in terms of not just funding projects and innovations, but also starting to look at implementation of the projects that we know works, because there is a lot of good initiatives out there. They're not necessarily very expensive, but they can go a long way in terms of improving the lives of those people that they do target. So there is a need to sort of get that transition into a rollout setting, as well as supporting new initiatives and innovations. Thank you.
Thanks, Stian. I think, Stian, you've just captured there the theme that everybody's touched on, and I'm going to ask Naji maybe to comment on that. And that theme is about keeping people away from the health services and moving towards giving them the tool, using technology to keep them away from health services and to give people, individuals, the chance to look after themselves more effectively. Naji, I think you touched on that as well, this whole concept of using technology to drive self-care.
That's really an important thing, using technology to allow people to live independently, and especially people who are living alone. And this is always a challenge, to look after people who live alone. And you'll be surprised, with the aging populations, and the spouse, one of the, partner dies. And there are a lot of people who live alone in rural, semi-rural area, but also more in big cities. And they sort of, you don't mention the big cities, but can be lonely existence in towns and cities when people live alone. So the challenge is supporting people to live alone with their ailments, and many people will have ailments, sadly, as we grow older, but also to kind of combine it with independent living and mobility. So people living alone doesn't mean staying at home alone. It means going out, meeting other people and so on. So the technology has to be basically designed to support people in their own home, take into account their different ailments, but also to keep them engaged socially. and to keep them basically mobile as much as possible, prevent falls, which become very important issue as we age. One thing though I find for the challenges of technology and the devices, and now there are many devices and people are attaching devices to their, kitchen fridge. It tells you how many times, if an elderly person open a fridge 20 times, that's normal. And if you suddenly they're open it for twice in 24 hours, something abnormal. You can monitor blood pressure. You can monitor, urinary infection. And so there are a lot of these technologies now that Shadi mentioned TV and, monitor, and there's a lot of technology. The problem is the technology is cheap relatively when you install it, when you use it. It's the monitoring bit that is the expensive and the challenge. Technology produces massive amount of data. What do you do with the data and where the data goes? And this is, colleagues in primary care, GPs and people. So you go want to engage them in, with technology and suddenly say, all right, then who's going to monitor the data? If something is not right, who's going to act on it? So you do, clinical studies and you get funding for a period of time and you have 1 or 2 people sitting in front of a screen monitoring all this millions bits of data probably coming if you have a large enough study. But you go to primary care, it's reasonable, or secondary care and so on, and say, can you monitor this thereafter? They haven't got the time to run around every, blood pressure increases a little bit, or somebody has perhaps, white cells in their urine and so on. So we have to couple technology with monitoring. Some of them are easy to monitor. It can be monitored by patients themselves, by people living well, elderly people themselves, or sometimes by caregivers. But at other times, you need outside, medical monitoring or nursing monitoring. That's the challenge will become, that we'll always have to think about for technology. For nursing home and residential home, we're doing a little study, very little one, just a qualitative study with a group of 5 nursing homes to look about the acceptability of technology and monitoring of technology in a residential setting. That is easier because you have a 24-hour, staff on site, and then actually it can help them so they can spend more quality time with residents and with patients there. So so challenges of monitoring the technology, knowing that it is very, very important, and the data that is produced is very important. But what do you do with the data for a timely intervention?
Thanks, Naji. You've raised a number of really important points there, and I'd like to come back to that integration with social care point. But Norman, if I could come back to you, one of the other points that that Naji raised there, well, 2 really. One was, how do those that are acting in the health services as clinicians feel about adopting new technology that actually changes their role as well as some of the outcomes for patients? Do they generally welcome that? And how do you make sure that that's the case? And secondly, who pays for some of the things that we're touching on, not just the technology, but the management of data, as Naji said? Should we leave that to the private sector? Is it about integrating, government-based funding and support? You've talked about some big numbers in terms of medication with the private sector. So maybe if you could touch on the economics of this and how we manage the right level of investment in the right way, and also about how we encourage early adoption amongst health services of some of these technologies.
Okay, well, I think that there are always going to be pioneers, first movers in any sector. We've found that because of the benefits that we can demonstrate in terms of managing medication, monitoring, I mean, the whole thing about monitoring is extremely important. And you're right, technology has a part to play. The problem is that people are obsessed now with health tech. They call it health tech. And everybody is talking about incubators and health tech and so on. What everybody forgets is that technology is useless unless it's linked or joined to a service. That's the important thing. So what we look at is services that are enhanced by technology. And from our point of view, the technology has to be invisible. So when somebody uses one of our hubs and we do the monitoring, the individual patient or service user themselves switches the video on with a simple button, and they can switch it off with a simple button. So they don't feel that people are intruding. A lot of people who've been or tried to monitor using Alexa or any of these other screen devices, most of the service users and patients feel they're being spied on. And this is a really, really big problem. And the fact that they can control start and finish with us means they don't worry about people spying on them. And I have to say, my own personal feeling is that when people have sensors all over the house, checking their movements to and fro, well, I wouldn't bloody want it in my house. I mean, this is intrusion beyond belief. Oh, and I've moved out into that front room 3 times today, and I've not, excuse me. There is a question that I have for Najib, and I think this is something that really interests me. How do we assess whether somebody who is getting old is happy or not happy? Because I'm sure that as you get older, as you go through the stages of man and you start getting older, different things make you happier and different things make you worry. So do you notice over a period of years that what will make somebody happy at 90, given the fact that they're reasonably well and everything's okay, do they have the same inclinations towards happiness as someone who's 80, as someone who's 70, as someone who's 60? And the other thing, which I think is also extremely important, is finance. People, can they finance their old age? So we talk about whether someone's healthy, but if somebody doesn't have any money to spend, if somebody's always penny pinching after years of having plenty of money, is that the key ingredient in making somebody unhappy and depressed? Or is it the fact that they are immobile when they used to be mobile? So I'm really interested in what factors make somebody happy or unhappy at different stages and different ages of their life, because that means that we can focus more on those points than others. So let's have a look at how this works. And I'd be very interested to hear from the panel about their experiences with people of different ages and whether or not each of those different age groups has particular aspects of their life that they find more challenging or may work against them being happy. And I think financial side is left out always, and yet it's probably the single most important factor in people's happiness as they get older. So if I just come back to the very beginning, because you asked me about whether doctors and stuff, we have found that if you can show and demonstrate and evaluate, independently evaluate a service, they'll do it. What we tend to find people say to us is, it sounds too good to be true. Well, actually, a lot of what we do is too good to be true because it's simple. And I think when people get too hooked up on technology, they miss the point. The point is, it's the service that's important. Technology is the slave of the service, not the other way around.
Okay, thanks for that, Norman. We'll come back to the question of economics, but as Norman there mentioned, the concept of happiness and how it might vary with aging and a range of other factors, Najib, I don't know whether or not you'd like to comment on that.
Yeah, I can comment on it. The concept of happiness obviously is exceptionally difficult to define, because people think about happiness differently, and what is happy for me might not be happy for somebody else, might be a nightmare for somebody else. But overall, if you look at population in general, a different age group and so on, you understand by happiness, feeling of relaxation, feeling of enjoyment, your thymic mood, that is, your mood is not down, and so on. It becomes, so you look for the psychological factors of happiness. And for younger people, psychological factors of happiness is very important, because you can diagnose people with depression, for example, based on their psychological well-being. For old age, it becomes much more complex, because then you have to add the biological to it. And that is big, because there are biological factors for depression, which is, kind of counts against happiness. And that will become, as you age, you'll have more biological factors that will, for example, arthritic pain, for example, different things, loneliness, and so on. So will complicate the picture. Yes, I think people should look at happiness in different age group differently. I think it is lower threshold as we age, but at the end of the day, happiness should be almost be similar in some aspects among people, but it's always difficult to define. So that's as far as happiness. And I think Nora mentioned another thing, and this is an issue, if you still remember, or at least part of my introduction, about a study that we are planning to do. We start doing, it's 3 phases, little study, hopefully becoming a little bit bigger in due course. And I mentioned, it's about, colleagues mentioned the word monitoring patients. And I said, mentioned that it is not monitoring patients, it's supporting patients. Because the word monitoring, especially among older people, especially among older healthy people, I'm not talking about people who already have lifelong history of paranoia and psychosis. People don't like to be told what to do. In my practice, my clinical bit of my practice, when I tell somebody who's been driving 60 years and now has dementia to stop driving, they look at me and say, who are you to tell me what to do? I've been driving safely for 60 years. So older people in general, I don't know about, different countries, but especially in the UK, don't like to be told what to do. They don't like to be monitored. And the problem, if you look at it from a, psychiatry point of view, even people are doing well, sometimes monitoring it comes with difficulty hearing and poor eyesight and so on, can tip somebody into paranoia and psychosis. So we have to always, when we talk about the technology, and Norman was spot on, is to look at the effect of the technology on the of monitoring people on the mental health of the patient and the persons that you want to help through sort of tracking or monitoring.
Thank you, Naji. I'm going to bring Stian in.
Thank you. Just a couple of follow-up points here. I think one of the interesting things is happiness is, whether that's the correct word for it or not, but it's a crucial factor to take into account in all of this. And it's also interesting to see the World Health Organization's definition of health that is now, because that is different from what it used to be. Now we're actually talking about living well with the conditions you have, and that is good health. And that needs to be so, because it's a lot of different life situations, and everyone can have a high quality life with their own foundations for that. I think we'll give you a specific example from our world in terms of happiness, and that is that every year we do something we call the Road Worlds for Seniors. So we do an annual cycling championship, 4 weeks every autumn, where everyone using MotiView as the cycling and video concept are competing all over the world in all these countries. Last year we had 5,000 participants from 260 teams, and they went 156,000 kilometers in 4 weeks measured on these bikes. Now that is telling us something about motivation and happiness and thriving in the environment you're in, because you're given the opportunity to do so. So None of these things as human beings goes away with age, but the opportunities around us may change. So we need to cater for the situation where this can still happen. And we also have done an extensive project with the Sport England some years ago, and we now have the final report across England, where we use the EQ5D5L in the internationally standardized diagnosis independent test to measure, for instance, perception of general health. And using only 3 months of activity with the cycling video, the perceived general state of health increased by 14% on average on over 200 seniors living in care homes. That is really interesting because that shows the importance of being given the opportunity of being active in one way or another, how that affects your general perception of your health and your happiness. So I think we need to bring this into the picture again and make sure that we can, like you, I can't remember who pointed to it now, maybe it was Shadi, but in terms of seeing each individual as an individual and sort of ask, what do you want for your happiness, for your health? How does that make sense in your life situation? I think that is a crucial point.
Thank you, Stian. Alex, I'm going to come to you next. I mean, we've touched on the question of how many of the things that we talked about will work fully only if they're integrated: social care, health care, people having the tools to look after themselves. And Norman mentioned affluence or poverty. I mean, I think you're probably based around Newcastle, you know, where the difference in health and life outcomes vary by 10 to 15 years between Jesmond and somewhere like Biker or Elswick.
Yeah,
you know,
that's right. Yeah, it's 15 years. There's 15 years difference in life expectancy between where I live to the west of Newcastle and Biker.
So how effectively at the moment, I mean, this is a question not just for the UK, but elsewhere as well, are all of these things being integrated? And you mentioned data, which would seem to me to play an important role, so that we have a joined up approach to healthcare, social care, self-care.
Yeah. No, I was just actually thinking about we're kind of heading towards talking about sharing of data, because I was listening to what Norman was saying about you know, you've got to remember about the ultimate service. The technology is all very good. So there's as we've said, there's some amazing technology available to assist, but we've got to then look at the service and how it's all aggregated and used. And I think what's interesting around this is that there's a lot of activity on the legal side at the moment around sharing of data. So we had the introduction of the data sharing code of practice in the autumn last year, and the ICO's been consulting in February on privacy enhancing technology to facilitate sharing of data in the health arena. And I think it is that sharing, but also what that sharing looks like that's really quite critical. So we've now got in my world, I guess, but it all fits together. Consultations around, well, okay, we've got this kind of guidance and steer about sharing, but actually, what does sharing look like, and what are we talking about? Well, actually, sharing can take place through actually anonymized data, aggregated data, and then we don't need to worry in many cases about some of the legislation, and surely there's a lot of benefit in sharing it in that way. And what does therefore anonymized data look like? And then you get into the discussion around pseudonymized data, where you take the identifier of the individual away, so that the security, go back to what I was saying about trust and confidence, that security issue goes away, and you can still benefit from looking at that particular personal data. We've got consultation out on identifiability and what that means. So these are all, you may say, it's very legal, technical debate in some respects as to those things. But I think it's important that these things are considered, and we've got a sort of framework that then people can work to, and we can work towards achieving exactly what some of the other speakers have been talking about, trying to get this integration and fluidity with this kind of base of trust and confidence, and recognizing all of the things again that speakers have talked about, you know, that people don't necessarily want to be monitored all the time, and they want to be active. And there's a lot of technology, like we've been hearing about the cycling, you know, that there will be masses of data that doesn't need to be personal data, that is aggregated statistical information about different groups of I don't know, demographics that will be very, very useful in terms of trying to better help those aging parts of the population, I would say.
Great, thanks for that, Alex. That's really helpful. Shadi, I'm not going to ask you to address that, but please feel free to do so. I'm particularly interested in coming back to the question of, you know, whether it's that whole area of integration, the introduction of new technologies, or improving some of the systems that Norman touched on. The economics of this, clearly there's a massive dividend behind and around improving health outcomes and keeping people away from the sharp end of health services. Stian's touched on that particularly. Are governments investing enough for that, or can the private sector do all that heavy lifting when it comes to developing these technologies and integrating them effectively with health and social care systems?
Sure, I'll be happy to address that. But maybe before, I just want to echo what my colleague said before about aggregation of data and sharing of all of these data between different departments of the healthcare system, caregivers, etc. So I'll give you an example. So about 15 years ago, when I just joined the hospital to work as a physician, we luckily here in Israel we had a platform that was connected to all types of healthcare providers like hospitals, outpatient clinics, pharmacies, etc., etc. So whenever I was admitting patient, even at 4 a.m. when he doesn't feel well, he can't speak, or maybe he can't remember which type of medications he's taking, and I need to figure out first of all what caused this condition and how should I treat him. I could open his file. I can see exactly which types of medications he bought, which condition he has, what happened, with this physician and that physician. And then later on in the hospital, when the physical therapy team, the physiotherapist came to treat him, they could look and see what happened also, in the outpatient setting. And vice versa, when he went home, they could look and see what happened inside the hospital, etc., etc. This is very helpful, especially in acute conditions. When the patient can't remember what happened, what type of medication he's taking, the conditions, etc. And going back to your question regarding the financials, so we see more and more, governmental support and funding that is being given to this area. But I want to tell you about a meeting I had with a healthcare organization in the States. So asking the same question, listen, ask about, for when the patients are going home, they're trying to address this readmission prevention problem. So they're putting efforts and resources into hospital at home, remote patient monitoring, and ask, do you get enough reimbursement? Is it, well established? And they told me, listen, even it's still not very well established, or maybe there's a delay in getting the payments. We're paying out of pockets because these interventions showed us that we can prevent readmissions, we can reduce all of our costs, and that's why we're more than happy to pay even out of pocket until governmental support, government funding catches up, stuff like that.
Great, thanks for that, Shadi. That's really helpful. Does anybody else have a view on the economics behind innovation with reference to aging? No? Okay, well, can I move on to the subject of the sort of priorities as we look forward, so looking towards the future, starting to pull together all the areas that we covered. I'm interested in sort of working through each of the contributors and panel members and understanding what you think are the big priorities in terms of accelerating the progress that we're making with reference to quality of life and healthy living for those that are aging. And maybe if I could start with you, Norman.
Yeah, I think, to be honest, what I really like about what Stian's doing is obviously exercise is very important. The problem is that I think that people should be supported when they're in their middle ages, so when they're in their 40s, 30s and 40s, because once they're actually in this, in the mode of looking after themselves and being healthy, the transition into 60s and 70s and 80s is relatively straightforward. So my philosophy always has been that if you want to have a healthy aging process, you need to start preparing for that when you're in middle age, not all of a sudden have to face up to all the issues that are going on when you're in your 60s and 70s. I mean, the happiest day for me was when my 3 kids left home. I mean, that was great. They grew up and they're gone, and boy, was I happy, you know. And as you grow older, you then start to have different things which make you happy, different things that occupy your time, different things that give you cause for concern. But fundamental to it all is if you can keep moving and you can keep doing exercising as you grow old, and it's already part of your programming, then it's going to be a lot more successful than trying to do, as Stian's doing, is to go into care homes or other areas and try to get people who are already old and don't move an awful lot to get the momentum and remove the inertia so they're actually starting to move. So I think that more time and more focus has to be given to people who are in the what I call pre-retirement age, pre-retirement zone, when maybe it's 10 years before they even think about it. Then all the services and maybe we need to have an open university course on how to survive old age, something that tells us exactly what we need to be doing, because we're not taught, are we, about how things happen as we get older. No one tells us how we manage our lives when we get older. Nobody tells us how we should be organizing ourselves. The only thing we ever hear, I know I did when I was just starting work, was I've got to have a pension. This is how much I get contribute towards a pension. Then I'm told that by the time I retire, I'm going to have these millions and millions of pounds to spend, which never ever come about. And all of a sudden, you know, you've got other demands, you take risks in business, and you find that, you know, you're in a position where you don't quite have as much money as you thought you would, especially when you've got kids and grandkids and all the rest, who seem to be very, very adept at sucking money out of my wallet. But at the end of the day, the key issue is that you've got to start this early. If you start it early and you start planning for your, not retirement, because, you know, I think this is one of the other things about old age is there seems to be a conflation between old age and retirement. And this is something else I don't think that maybe people realize. Maybe Nadia will be able to help us on this, that when people retire, they become transparent, they become non-people. A lot of people I know who've retired just disappear from life. They just seem to, you know, a lot of them tend to wander around with their wives or whatever, shopping. It's really quite sad. I mean, the fact is that even if we can do something with our lives, some involvement in business or whatever, when we grow older, surely that will also contribute to wellness. And again, I think that it's not just one element. Yes, it's very important to be healthy, which means that, you know, you have to be fortunate enough to be able to take the medication, to afford the medication. The problem is that ultimately, when you start getting older, there are lots of other issues which you need to attend to. And we don't really understand how that works, because there is nobody who I believe is completely independent who wants you to have a good life. Most people want you to have a good life at their expense. So, you know, pension schemes, all sorts of other schemes seem to have been part of the process. but they don't seem to actually make any difference. So my view is that you need to prepare for old age. If you prepare for old age, then you're going to have a better life, and you're going to have a more happy environment. I don't know what everybody else thinks about this, and certainly throwing it into the mix.
Great, thanks very much for that, Norman. Stian, same question to you.
Yeah, thank you. I think we are actually not experiencing having to lift a lot of, or to create a lot of inertia to make the activity happen. Oh, sorry. Because the cycling and the things we provide is actually a very common part of life. And I think that is one of the keys, is actually to, that you referred to, Norman, is actually that you need to integrate with things that are a common part of people's lives, whether you implement that early or whether it's actually something that they already do. And that makes a lot of sense to us as well. I think in addition to the points I mentioned earlier with regards to mindset and obviously funding to implementation, not just projects, I also think that it is a key, and this is probably hard to find somebody who disagrees on, but I still think we need to implement it in practice more and more, is the collective cooperation around these challenges across the sectors, across the health system, the private sector, the third sector, because it is a huge undertaking, and we're all coming at this from different valuable angles, but it needs to be integrated if we are going to succeed with these challenges, whether that is changing somebody's lives from the inside or providing better support with medication or how to handle the data and analyze and benefit from that. So I think there needs to be a strong focus from every angle, from all initiatives and all systems, in terms of cooperation and building this alliance broadly.
Great, thank you for that, Stian. Shadi, can I ask you the same question, please? The big priorities as we look forward.
Sure. I think Norma said before that technology needs to be coupled with a service, and we have great healthcare providers. We have also services in outpatient setting. We have cool technologies out there that can help patients. I believe that the integration, interoperability, and data sharing between all of these is essential to make all of them work together. Exactly as Norma said before.
Great, thanks, Shadi. Alex, the big priorities as we look forward.
Yeah, I'm just picking up on some threads that have already been touched on. I think what Norman was saying about education really resonated with me, because I do think that certainly here in the UK, it's been subject of a bit of discussion at home actually, there's a real lack of education around basic life skills, which I think is what Norman was sort of alluding to. And you do need to learn how to look after yourself in all aspects of life, whether that's financially, well-being, health, fitness, and I don't know, I feel like some of the things that perhaps people were taught historically have sort of dropped off, and there's been quite a, maybe it's shifting again, I don't know, but there's been quite an academic focus, which is fine. It is fine, and that is all needed, but you need the whole thing if you're going to look after yourself. And I think we talked about variances in life expectancy. You have to say, well, how much of that is due to the education side of things? So I think there's that. I think we need to have a look at digital poverty, because we've talked a lot today about technology and what's all of the amazing things that are available that we could do and service provision, but the pandemic showed that actually there is a large proportion of the UK population that doesn't have access to some of this digitized offering, and we need to think about that. We can't just assume, I don't think, that everybody's going to necessarily be able to access some of this stuff. So how are we going to address that? So I think those two things in particular do stand out for me.
Great, thanks very much for that, Alex. And Naji, same question.
Yeah, to be honest, there are so many priorities. Sometimes it's difficult to know where to start. I just want to, start of where Alex ended. It's about the digital poverty, but I'm looking at it is among older people, and this is an aging, round table, aging health round table. Among older people in particular, the technology needs to be basically delivered to people who probably either cannot afford it and more likely cannot understand it. And that's the challenge for inventors and for us clinicians and everything, to make technology understandable to older people. I say that knowing that more and more of maybe 15 years ago, hardly any of my patients would have used a smartphone or iPad. You'll be surprised the number of older people who are now technology savvy, but it's still much less than younger people. Therefore, the people who need technology most need to be helped to be able to use it. That's before we add the poverty factor and so on. That's one. I will also go back to what Norman said. Also raised an important point about retirement time. Actually, retirement, and especially the first few years of retirement, is a very stressful time for people. And you combine this with you look forward to, especially, you've done your job for many years and you look forward to retirement, but there's such a change that among older people, it's like moving house. And if you look at the first few years of retirement, there is high incidence of mental health issues and many patients presenting with depression and with anxiety and so on, because that's a significant change in people's life. So that's a priority to look at that, and you can start addressing probably pre-retirement. And it's always for me about, revisit the issue of about monitoring without using the word monitoring, but how do we optimize the use of the data generated? It's like buying a new car, you buy a new car, has so many gadgets, so many things. 3 years later, you haven't even, learned how to use half of them. And the same thing with this data, you generate so many data. Are we using it all, and what do we do with it? And, a final point really from me is develop technology, test technology, because there is a pressure on inventors, on startup companies and so on to go to the market quickly. Yet the best technology is the technology that has been tested in the field, clinical assessment of the technology. And here I want to introduce the word co-production, is that you have to work with, yes, the clinicians and the experts, but also with the people who will end up using the technology, the service users, the users. And they are partners in the production, should be partners in the, production. That's why, it's a buzzword, co-production. And yeah, so and doing all this to support people age well, and if they have ailments, to live well with their disease. And hopefully enjoy life and be happy as much as possible.
Thank you, Naji. I think that's a great way to conclude our discussion this morning. But before we do just round things off, I'd just like to ask the panel members if anybody has any last comments that they might have, or if there's any areas that they'd like to raise before we conclude the discussion.
Yeah, can I just make a quick statement? And this relates to Paul more than anything else, because when Paul gets old, he's going to be miserable and unhappy because he supports Sunderland Football Club, and there is nothing he can do about that. Is that right, Paul?
I think Paul is quite rightly not going to be baited by you, Norman. The question of football.
I'm not really sure how I can get more miserable than this, to be honest.
And I do think if we're going to link football to happiness, quite a few of us actually are destined for a fairly miserable old age.
Yeah. So who do you support then? Tell me.
Oh no! Coming from central Scotland, that's a very dangerous question, Norman. I'm not gonna get into that. But that was a slightly more controversial way, possibly, to finish our discussion this morning. But it's nice to be able to have a bit of a laugh because we've covered some quite serious topics and a lot of ground. I'd just like to remind everybody that the discussion will be loaded up onto YouTube, so it'll be there for everybody to share. It'll also be available, more importantly, on the Health Tech World website, and we'll be using a lot of the content to let people engage with this discussion through social media. So for all those watching and for our panelists as well, let's share this fabulous discussion as widely as we can. I think we'll probably come back to some of these issues and maybe rejoin this discussion a few months down the line because it's a fast-moving area. But I'd just like to thank all of our panelists for giving up their time this morning. It's an incredibly diverse, knowledgeable and experienced panel, and I think the discussion this morning has reflected that. So I'd just like to thank all of our panelists for their contribution this morning. To everybody that's watched, thank you again for being involved and watching this Health Tech World Roundtable, and to Paul for making things happen behind the scenes and for putting up with good humour some of the baiting that we saw from Norman there about his football team. So enjoy the rest of the day and the weekend, everybody. So thanks very much again.